We would love now to introduce our next speaker, who is Dr. Amadou Garba, who is in charge of the schistosomiasis control at the WHO Department of Neglected Tropical Diseases in Geneva, having previously worked in the African countries, having had 25 years of experience in schistosomiasis and other tropical diseases. So we really appreciate your intervention, Dr. Garba, and we welcome you to our session.
Thank you, Chair. It's really a pleasure for me to participate to this MSF Pediatric Days. Thanks to organizer for inviting me. And it's also a pleasure for me to speak about a neglected tropical disease, which is schistosomiasis. It is among the 20 NTDs that have been previously presented by Gabriel. So the NTD department has developed and launched last year a strategic document for the decade, which is the NTD roadmap. So this important document has been endorsed by the World Health Assembly, and it is aligned with the Sustainable Development Goals. So the aim is to eliminate the NTDs in the decade with some programmatic shift that are the ownership of the program by the endemic countries, the implementation of cross-cutting activities, and also moving from, I would say, moving to impact indicators. So this document is followed by what we call companion documents that provide more explanation and details on the implementation. So we have a sustainability framework. We have a framework for M&E. We have a document on WASH. We have also a document on One Health. All these documents have been published and they're available on the WHO website. So the targets that have been set for the decade, the overarching target, the first one is the reduction of the number of people requiring intervention in endemic countries. So we need to reduce people that need treatment for schisto, for LF to trachoma by 90% in the decade. This is important. We need also to have reduction in the morbidity due to the disease by a decreasing of 70% of the DALIs due to the NTDs. And then in terms of countries, we would like to have 100 countries having at least one NTD eliminated in the decade. So this important document is our guidance document for the decade, for the 10 years to come. With regard to schisto, we have set some target and milestones that you can see on this table. We have two. The main one is to eliminate schistosomiasis as a public health problem in all the endemic countries. And the second objective, which is a sub-objective, is to demonstrate the interruption of transmission of schisto in human. Because we have two categories of countries. We have very, very advanced countries where the interruption of transmission can be expected. We have also countries that now are working to eliminate the disease as a public health problem. So for making that, there are critical actions to be undertaken. The first of them is the effective implementation of the intervention to all population in need and assuring the access to the necessary medicine. And the second important one is this access should include all, including the children. So what about the distribution of the disease? The disease is distributed or endemic in 78 countries globally, and 51 of them require mass drug administration, what we call preventive chemotherapy. And in terms of numbers, we have 242 million people that require regular distribution of praziquantel. We have also publications that reported transmission of schisto in some countries, but this need to be confirmed. We have reports from Nepal, from India, and from Myanmar. And also, in Europe also, in Corsica, we have also transmission of schisto. It's in Europe, Southern Europe, in France, of schistosoma hematobium in 2 transmission sites. And this is progressing since 2011. What about the cycle of the parasite? So we'll start here by the eggs down here that need to be released in fresh water. So we have the S. hematobium, which is the urogenital schistosomiasis eggs that is released through urine. And then you have the other eggs that are eggs for intestinal schistosomiasis, Japonicum, Mansonii, Mekongai, etc. So these eggs are going to hatch in the fresh water. They have to penetrate competent snails because there is a need of the presence of this snail on the fresh water in order to have the cycle continue. In these snails, the parasite is going to be transformed and it will release an infected form, which is the cercaria. So it is this cercaria which is going to penetrate the skin of human and infect people. So schisto is not a disease that you can have by drinking water, but it's a disease that you can contract when you are in contact with fresh water that is contaminated by the parasite. So in the human body, the parasite is going to be transformed, and the final form of the parasite is worm. So there are worms that are not going to be in the intestine and seen in the stools. No. The schisto worms are worms that are going to live in the blood vessels. So it's from the blood vessels that they are going to release the eggs that are going to have a tropism according to the type of schisto. In the urogenital schisto, these eggs are going to be released in part outside the body through the urine. The remaining eggs are going to be kept in the body, create inflammatory reactions, create granuloma, and induce the pathology. And this is the same for the intestinal schisto, where the eggs can go to the liver, create the fibrosis, and the remaining eggs are released in the stools. So this is in short the life cycle of schisto. You need to have infected people, you need to have freshwater plant, you need to have the snails in order to have transmission of schisto. So, what are the group at risk of schistosomiasis? The main group known by everybody is the school-age children, but schisto is not limited to school-age children. Schisto is transmission of schisto is about contact with water plant. So we have preschool-age children that are also at risk group. We have adults that are in contact with the water plant because of their occupations. I mean the fishermen, the farmers, the rice growers, etc. And importantly also, we have women because of lack of appropriate wash at home, lack of clean water, for example. They have to go to the river or to the lake to do their domestic tasks. So they represent a risk. And sometimes the entire community is at risk because of the lack of wash and also because of all the life of the people in the village are linked to the water plant for having food and also for all the activities and also for social activities. So in terms of clinical manifestations, I've already said that we have 2 forms, the urogenital form of schisto and the intestinal form. With regard to the urogenital form, the main clinical sign is blood in urine. So you can see on the left, these cups are full of urine of school-age children in a school in Niger during a survey. So you can see how the disease can lead to loss of blood and have a consequence in terms of anemia. So you can also have bladder lesion to the granuloma and inflammation. You can have later on development of bladder cancer. With regard to the genital form, it can affect both men and women. In women, you can have a lesion on the vulva. You can have lesions in the vagina. WHO has developed an atlas for the diagnostic in the vagina. You can also have lesions in the upper genital tract. In the fallopian trunk, you can have granulomas that are going to stop the fecunded eggs from moving to the uterus, having ectopic pregnancy, bleeding, death. You can also have sterility from these consequences. So the manifestations are large. You can have also just low abdominal pain in women, etc. In men, you can have hemospermia. You can have also pain during sexual relation, etc. With regard to the intestinal forms, you can have blood in urine, blood in stool. On my left here, you see this is stools from a very young children, I think of 4 years of age. You can have diarrhea, repeated diarrhea, and the nutrient lost. So you see the blood loss, the nutrient lost, and in the advanced phase, you can have portal hypertension with ascites, hematesis, and death. Yeah. So you can see the infection of young children. It's something which happened very early in life, because after the first month of after birth, most of the time after women after 40 days, they can go outside for their activities. And one place for these daily activities of women in rural area is the river to clean the dishes, etc. And you can see children are exposed. This baby can be who is in this bucket. The bucket is filled with infected water, and the baby can sit down here while the mother is doing her activities for hours. And during all these hours, you have cercaria that can penetrate the skin and infect this young baby. And this is something which can happen, I would say, daily. So it's a kind of repetition of infection every day. And you can imagine that it's easy for them also to have this morbidity. Here, it's a young girl of 5 years with bloody urine. And here you can see all the community in the water plant. So, given this importance and this infection in young children, WHO has convened a meeting in 2010 to review the studies. And you can see on this table in Sudan, for example, the prevalence of infection in 1-2 years old for S. mansoni hematobium. You can see here at 2 years, 32.6% were infected. When you move up at 4 years of age, you have 43.9% of the kids that are infected by S. mansoni. And when you look at the infection with cattle cats, you see 63.2% among the children aged 3 to 4. So the infection rate can be very, very high, and the morbidity also high in young children. And it's an age group that should not be really neglected. On this table, taken from a publication from Traoré in Mali, you can see the infection rates here in the community according to the age. And in 2 to 6 years, you have 52.8% infection rate, and 10% of them have high intensity infection. And you have also lesions that can be observed at ultrasound you can see 32% have bladder abnormalities. You have also upper urinary tract affection. So you have dilatation of the ureter, and also you can have a dilatation of the pylon in 12%. So the morbidity also is something that can be seen in young children. So in summary, the early sign can be dysuria, blood in urine, blood in stool, hematuria, abdominal pain. And this, you can also have occult fecal occult blood in S. mansoni infection. And use of ultrasound can help detecting the lesions in the bladder, in the kidney, in the liver, in addition to the parasitological exams. So WHO has released in February a new guidelines for control and elimination of human schistosomiasis. In this guideline, there are two recommendations related to the treatment of young children. The first one is to include them in the preventive chemotherapy activities. I mean, inclusion of young children in mass drug administration campaign. But in order to make it happen, we need to have a pediatric formulation of praziquantel, which is currently under development by Merck. So it's going to be, the trials are completed. It's going to be available soon so that we can include the very young children in mass treatment. The second recommendation is about treatment of all young children, even those below 2 years of age, because we have seen that they are exposed also. But this treatment should be done based on the clinical judgment and the diagnostic test. So if you have blood in urine coming from these young children, you can treat them with praziquantel. And in this case, while waiting for the pediatric formulation, you can use crushed praziquantel tablet in order to treat them. So schisto can represent a significant public health problem in young children. And the administration of praziquantel to preschool-age children is acceptable, it's safe, and it's efficacious. We have done a review of treatment of preschool-age children data with regard to the safety. We have done also systematic reviews on the safety of praziquantel in all age group before making the guidelines. And this show that this medicine is really safe and efficacious. Thank you. And before ending, I would like to show you some images of schisto from Uganda. So you can see on these images, there are really very young children infected by schistosoma mansoni with this characteristic sign of big stomach, and also you have the stools. So here you have the consequences if not taken in charge early. If people do not receive this mass drug administration, they will evolve to complication. And here you have complication in very young people with ascites. And this is really sad to see, to continue to see in that in some communities. And here you can see this is an hematesis due to schistosomiasis in a health facility in Uganda. Thank you for your attention.